So what we're going to cover with this workshop is just talk a little bit about the health authority, talk about that we call our public health system that we're still developing and establishing it within our organizations for the communities we work with. So talk a little bit about, it's called Approaches to Community Wellbeing. And we're going to talk about how housing impacts health, and maybe share a model how public health approach is done in another country to healthy homes. So we've been around since 1990. We were established by the Sioux-Lookout Chiefs. There was a study that was, study that was done in a report with Scott McKay Bain, and that's how they said that we should. They recommended establishing a health authority. We are governed by the chiefs of the communities that we work with, and we have a range of services that we have taken on over the years. One of them is we have a hostel. We built a hostel, and then we recently bought a hotel that was for sale. So we probably, through our client services department for medical transportation and accommodation, we probably see about an average of 200 people a day that we accommodate and drive around to their appointments and stuff. So we also do management of physician services. We have mental health, which is called NODEN, and we're also in the process of really developing developmental services around, especially around special needs for children and youth. We were able to get Jordan's Principal money, which has been a really great program as we're developing it. We have a primary care team that we've been establishing for the last couple of years, which is physio, dietitian, and everybody else said that. So we're building teams that can provide service, hopefully, to a group of communities as we move on. We certainly have challenges in providing services at the community because there's no workspace and accommodation that people can stay in. So that's a real challenge in all of our communities. And then we have Approaches to Community Wellbeing, which is our public health system that we've been developing for about 3 or 4 years. So this is the area that we cover, the communities. We are, our farthest community that we serve is Fort Severn. We work with tribal councils. We also, with our public health, we've been working with the health units because they divide our community right down the middle somewhere. So we work with both of them, and they've been really supportive as we've been developing our public health. They've been doing it for a long time, not like us. Jonathan, can you give me some Kleenex? Okay, sorry. I was sick for about a month, just in the new year, and I'm just slowly getting better, but I'm not contagious. So I did talk about this. So one of the things we're able to, because you know how governments, and I'm sure that you communities come across this with inadequate funding, and even for building homes in the communities, and so we're able to get funding to start doing some of this work through health integration funds, and we did community engagement, and we developed a model with the communities, and the chiefs approved our model, and then we were able to get funding through the province, and we're still moving. We still have a long ways to go, but we've been able to get a public health physician, which is Natalie, and we had to do a secondment through Thunder Bay Regional or Thunder Bay Health Unit, just because legislation prevents us to have her be in the health authority, and so they appointed her as associate medical officer of health through that process. We're also trying to deal with that. So just talking a little bit about our model of public health. We haven't developed all the areas yet, because some of it is we don't have enough resources, but we're also trying to also help the communities really define what their public health system should look like in the community. And sometimes that's slow going, especially with all the crisis situations that happen in the community, and people get pulled into those acute care needs of the community. So we did work around developing the vision for what our public health or well-being model should look like, and we did it with community people, health directors, and we were able to develop a model with them. And this is what we have in terms of what our public health system is around healthy living, raising our children, safe communities, and roots for community well-being. We started with raising our children first, because because there was such a high need there in terms of family health and youth development. So we have youth facilitators and trying to build a supportive system for the community. We only have 2 people, and we have 33 communities, so sometimes a bit challenging. And then we have healthy living, preventing infectious diseases, and we've been working on that in the last year, and we're going to hopefully April 1st. We are going to be responsible for communicable disease management and reporting. So in the public health system, there is reportable diseases that that are outlined, and so some of the stuff, some of it because that we see situations in our communities that could be different from mainstream. So we've talked about what else, not necessarily mandated by the Public Health Act, but what else can we report? Like we saw couple of years ago, we saw rheumatic fever in our communities, and so we're talking about things like that to monitor. And we're just talking about also skin infections and things like that. So as we build our system, it's not going to look like exactly like the mainstream public health system. We haven't done anything on environmental health, other than we did have a forum just when did we have that? January? And so waiting for a report from that forum that will help us move forward in that area, what communities would like to see for environmental health in their communities. And the other thing, in terms of roots for community well-being, we've been able to develop some reports, one on children's and youth health status report, and we just finished on adult. So, which is, it took a while because we don't have direct access to the data. Sometimes we had to sort of negotiate for us to have access to it. So why is ACW interested in housing? And I think for us, our system has become so fragmented, and I think why we are interested is that that we need to approach healthcare and also health services in a program in a holistic manner, so that it's more comprehensive. So when we do see, not me, but when the physicians or other healthcare providers see people that maybe it's attributed to housing, we know that mental health is a huge issue that comes like with overcrowding and things like that we see in our youth, where they don't have their own space, and so we see lots of youth that are high risk. And I'm not saying it's just because of housing, but I think if they were in a environment that was more supportive, they certainly would be able to maybe cope better. So the next part Natalie's going to do, right? Yeah. So thank you very much, and we'll have time for questions at the end of our presentation if anybody has any questions. Thanks.
So good morning, everybody. As Janet and Jonathan mentioned, my name's Natalie. I'm a public health doctor, what does that mean? So we try, physicians, your family doctor, and I used to be a family doctor, treat individuals, right? You're seeing people in a clinic and you're dealing with whatever health or wellness issue they've come to see you about. Public health physicians, their patient is the whole community or the whole population. So we tend to look not just at kind of what the immediate health issue is, but what all of those upstream underlying determinants are, where if we were to make changes at that level, then we're going to see the biggest change of health status at a community level. So that's really, really the focus of public health. And so when people ask, what is public health? So the reason our program is called Approaches to Community Wellbeing is because the terms public health didn't really mean anything at community level. I think, mainstream Ontario, most people don't know what public health is or what public health does. So public health was kind of translated to mean community well-being. And how do we achieve that? Really, public health is about three things. It's about preventing illness or preventing disease. It's about health promotion, so wellness, and it's about community level or population level, moving beyond the individual. And so those are kind of the three things that I come back to when we think about what our role is. We talk a lot in public health about the determinants of health, or the sometimes called the social determinants of health. And partly because I like to remind everybody, my husband, my 3-year-old, everybody, that really when you think about what contributes to the health status of people, of communities, health care or the healthcare system actually contributes less than 20%. So that means you have really 80%, the majority of other things contributing to health status. So 40% is actually related to underlying socioeconomic factors. 30% is related to health behaviors. And I would say that most health behaviors are not individual choices, but they're rooted in the environment and rooted in your social surroundings, your networks. And then at least 10% related to kind of physical environment. So housing is one of those really key underlying determinants of health. In addition, so in this diagram, this is kind of what we would call or is the main global framework for social determinants of health. There's different, you can adapt it in a lot of different ways. Some folks out of BC have developed a web of being, which is an Indigenous approach to the determinants of health, because we know that, I mean, in some lists, when you look at the lists of what are the determinants of health, you might see Aboriginal status listed. But Aboriginal status is not a determinant of health. What makes health outcomes different, often for First Nations, Métis, Inuit communities, is the parts of history that are associated with that. So colonization, residential schools, intergenerational trauma, those are the underlying determinants that are actually contributing to health outcomes, not the fact that you're Indigenous or First Nations. So we can, in the middle of kind of the center of the framework, you start with the individual, and there might be certain factors of the individual, age, sex, that will help determine some health outcomes. And then there's your behavioral factors, lifestyle factors. But moving beyond that, you move to social and community networks, and then the underlying things that really are the majority of what is going to contribute to your health outcomes. So education, work environment, other living and working conditions, water and sanitation. And again, housing is probably one of the biggest ones that we see, certainly in the region that we work in. So this is just, and so this is BC First Nations Health Authority that's developed kind of their public health approach that looks, again, so you start with the individual and then you move outwards. And we see kind of housing fits really within that big, broader perspective. So if we're to look at housing specifically and how housing impacts on health, there's lots of different ways you can carve it up or describe it. One way I think that helps keep it holistic, or thinking about all of the different aspects of wellness, is thinking about how housing affects emotional, physical, spiritual, and mental health. I think we often focus on the physical aspect, but it goes well beyond physical health. If we think about what is it in about housing that contributes to physical impacts. So if you look at the red circles kind of around the house, these are kind of the main contributors of what will lead to different health outcomes. So crowding is a big one. We know that crowding relates to physical health outcomes. Waste management, wastewater management, other waste management, drinking water, physical hazards directly in the house, indoor air, the air that people are breathing in, and then the presence of pests in the home. And there's good evidence really from a variety of studies around the world looking at kind of what there's evidence for. And there is directly evidence related to respiratory health. So whether or not this is underlying asthma or whether it's related to infections. There's good evidence related to the impact of housing on skin health. So skin health, whether or not it's related to eczema or related to dry skin. And then as soon as you have a break in the skin or an opening and there's an opportunity for bacteria to get in, then you'll develop a skin infection. And certainly in settings where there's overcrowding in a home and there's not access to kind of what you might call health hardware, like running water, that sort of thing in the home, then you have increased bacteria in the home. And it's easy for your everyday bacteria to be passed from person to person and get into that little break in the skin and cause skin infections. Heart disease, headaches, we know, so Dr. Kovesi was talking about in his presentation, the presence of things like volatile organic compounds, the presence in terms of indoor air related to particulate matter. From a population perspective, we know that particulate matter contributes to heart disease and respiratory disease. So certainly its presence indoor the home, if there's a heavy burden, there's associations. Physical injuries, so falls, burns, these are your immediate health hazards. And then gastrointestinal infections. So these are some of the more obvious physical impacts that we see. If we look at mental impacts, so and similar kind of things about the house itself, the features of the house, but associated with, so sleep deprivation. And sleep, I think sleep is something we often ignore or we pretend we don't need, but there's more and more evidence of the relationship between sleep and just wellness, especially for kids, and the need for sleep. So I know in our region we have houses where there's 20, 30 people that share a house and need to sleep in shifts because there's not enough places for people to sleep. And so the impacts of that on, children as they're developing as well as adults and their health are huge. Early childhood stress, mood disorders, so anxiety, depression. I think we can link certainly components of housing to each of these different things. When we look at emotional impacts of housing, so certainly in our region, there's lots of emphasis, lots of discussion, and lots of concern around the prevalence of addictions. I think the region was particularly hard hit by the opioid epidemic. We don't necessarily see overdoses the same way that you do in urban centers, but we see the impacts related to infections and serious invasive bacterial infections that are infecting your heart valve related to injection drug use, as well as breakdown kind of your family and your core units and social networks. Stigma, isolation, lateral violence. I think housing plays a role in all of that. And I remember talking to the health director of one of the tribal councils who had been up in one of the communities after there'd been a recent youth suicide, and they were at the young girl's home. And she talked about the cockroaches that were kind of all over the house, and said how, as a 12-year-old, how are you're going home every day to this environment, and how do you stay mentally healthy and emotionally healthy there, with some of the features of the housing. So we know that in particular overcrowded housing has been associated, and this is kind of a small list, but where if you were to go back and look through kind of this different scientific studies, that there's evidence for the relationship of overcrowded housing and higher rates of respiratory infections. And so that could be upper respiratory, or it could be lower respiratory, which is more pneumonia, higher rates of skin infections, higher rates of rheumatic fever, malnutrition, and stress, anxiety, and depression, I think particularly among children. If we look again at some of the evidence, and this would be your scientific studies of poor indoor air quality has been associated with respiratory disease, whether or not it's kind of an allergic or an asthma component, or if it's infection, as well as other allergy symptoms. So it's challenging in public health because we don't actually have any control over housing, right? Or control over education, control over these really important determinants. But yet we know that they're actually the most important contributor to health and to health status. So how do we work across sectors, or what is the role of public health in trying to work towards this? So there's a couple of different ways that I have seen public health involved. So one of them is around kind of just measurement, numbers, data. And so this is more about kind of linking, so understanding the health status. What are the major health problems that are affecting the community overall? So public health, we will look at kind of the broader statistics and be able to say, so, in this community, the main reason that people come to the nursing station is skin infections. We know that the main reason that people are admitted to hospital is respiratory infections. And so how do we go back and use that health-related data in terms of housing or trying to improve the underlying determinants? There's a role, so public health is often involved in setting kind of the health standards around things. So there's indoor air quality guidelines nationally. There's different work done at, say, Public Health Ontario around the role of environmental health and its contribution to health. One of the largest areas is probably advocacy in terms of connecting and partnering with different groups to lend kind of that additional voice to what some of the priorities are. And I think that we know that federally for a long time, it's only really been about, well, we've given this much money to housing. It hasn't been about, you know, there's this many more houses, this many quality houses, and then it's led to these health improvements. It's just about, we've given this much money, which doesn't really say anything, and it hasn't changed anything or made a difference, really. So how do we start looking at the bigger picture beyond that? And then public health has a huge role in education, so community level education and looking at health promotion. And I think in particular, actually I don't think public health has necessarily done a fantastic job, because we know that things like posters up at the community hall or in the nursing station aren't always the most successful approach to health education. So it's really looking at how do you connect with people to reach those people that need it, that would benefit the most from some of that education. And I'll talk a little bit later on that I think there's real opportunities to partner some of the work that's done in housing with health, and look at, because housing inspectors, those are the people that are seeing or know kind of which families are maybe struggling the most. And is there a way to support that with other health promotion or other activities in the home? So there's lots of definitions, like what does healthy housing mean? And I think each community can define it in their own way of what it means for them to have a healthy home. The World Health Organization has a definition of healthy housing. So shelter that supports a state of complete physical, mental, and social well-being. It provides a feeling of home, including a sense of belonging, security, privacy. Refers to the physical structure of the dwelling and the extent to which it enables physical health. But so this is the World Health Organization. I don't think that that's necessarily what would be adopted or promoted at each community. I think that you can look at it holistically, and when you look at foundations of wellness for Indigenous health, it goes much further beyond than just the physical health. So it's an interesting, so what does a healthy home look like, right? A healthy home doesn't necessarily mean that every surface has been bleached and there's no bacteria and there's hand sanitizer at every corner or that sort of thing. But so this list, I can't remember actually where I got this list from, but so some of the features, so meets building codes, has safety features to protect the occupant. So safety features are things like smoke alarms, carbon monoxide detectors. You know, for children is the hot water heater, your boiler set to 39 degrees Celsius so that kids are not likely to scald themselves with hot water. So adequately heated, ventilated, has clean drinking water, free from pests, free from indoor contaminants. So I came across this organization in Australia. Has anybody here heard of this work? Anybody from Australia? No? Okay. So I can say whatever I want, really, and make it up. But so what I really liked, so this organization, it's a nonprofit organization that works not just with Indigenous communities in Australia, but also other communities. And it's essentially on housing for health. And so the focus is on housing impacts health. And their whole approach is that even in a building inspection or in kind of how they prioritize repairs at the house is based on health outcomes. So what and they've developed this guide called Housing for Health, and it's based on 9 healthy living practices. And so these pictures, you have to look closely to figure out what they're trying to say. And again, this is Australia, a very different environment than Canada. The health outcomes that are prioritized may or may not be the same for our region. So the point isn't that this should just be like adopted and we should do this program. But the idea is kind of the approach that you're looking at and prioritizing things based on health outcomes. So the first thing that they look at before even the 9 healthy living practices are immediate safety risks. And they divide that up into kind of 4 priorities. So what are ensuring there's no opportunity for electrocution, gas explosions, asphyxiation, injury from fire, or structural collapse. So the immediate big safety issues would be first priority for repairs or maintenance. And then what's interesting, so in the first 3 healthy living practices are really not about structural issues in the home. It's more about having access to the tools to prevent different infectious diseases. And so they have prioritized based on their health outcome information or their understanding of what is making people sick in the community, that skin infections are really important, respiratory infections, and gastrointestinal, so like stomach infections, diarrhea, that sort of thing. And the 3 things that contribute the most to that were that in every house there was somewhere that people could wash. There was a working shower or bathtub, and they had access to running water, and there was enough access to that. The second, that there was access to washing, bedding, and clothing. And then the third was more about removing wastewater safely. And all of those were really, of all of the different problems you can have in a house, contributed the most to decreasing the burden of infectious diseases in the home. The next kind of bits, the 4th one was related to nutrition. And so understanding that what are the essential prerequisites in a home related to nutrition, like in terms of infrastructure, that there's some place in the home that you can store food safely away from pests, that there's some ability in the home to prepare the food that you want to be able to eat, so that you're not having to have takeout or that sort of thing every day, because there is a place in the home that you can do that as part of it. The next section was really a mix of what the health outcomes were. So it's a mix really of decreasing infectious diseases, decreasing chronic diseases, and improving mental health. And so these priorities were looking at the impact of crowding, reducing the impact of animals, insects, and vermin, reducing the impact of dust, and improved temperature control. And then the last one was related to decreasing injuries or reducing minor trauma. So again, I'm not saying that these are necessarily things that we need to automatically start doing here, because when I think about in our region, what do we know about health outcomes? So for the 31 communities that we recently have been starting to do health status reports for, we know that actually the number one reason that both adults and children encounter or come to the nursing station for encounters is skin health. And that's not necessarily all skin infections. It could be eczema, dry skin. It could be related to scabies or pests. But it's the number one thing that brings people to the nursing station. We know that for emergency department visits, so for the majority of communities to go to an emergency department, you need to get on a plane or drive on a winter road. So most people are accessing the nursing station first for services. So if they make it to an emergency department, after injuries, the leading kind of reason they're seen is respiratory health. And the leading reason, especially for children, of admission to hospital is respiratory health and respiratory infections. So if we were to look specifically at what are the things in homes that are contributing to those health outcomes, and we were able to support people to make the changes needed in their home to decrease those health outcomes, we would see kind of that some of that change in health status that we're working towards. And right now we focus a lot on, well, what's the quality of care once they're sick already? Or do we have access to doctors? Do we have access to the medications? And that's important. But if we continue to really only focus on that, it's not going to change, because there's only, even in a perfect healthcare system, that's not going to change the actual health status and experience. They're still going to have skin infections and issues with skin. There's obviously, again, different climates, but I think it's about thinking about what the approach is and linking those aspects of housing to different health outcomes. You have to tell me to stop eventually. So I think the other part that we often forget is moving beyond the individual home, right, to healthy communities, healthy neighborhoods. There's certainly in urban settings, so we call it the built environment. We know that the role of the built environment in health is huge. And we keep saying, or I keep reminding people that until the healthy choice is the easy choice, we can't expect people to always choose the hard way, right? We can't, if it costs more money to eat healthy food, we can tell people to eat healthy food, and some people will be able to do that. But most people won't, and it's an unfair expectation. So until the healthy choice is the easiest choice, we're not going to see those behavior changes really at a population level. So when we think about the built environment, we're thinking about in some of the remote communities, so it's like, what's the layout in the community in terms of even walking, accessibility, access to kind of essentials for daily living like food, the store. Impact of dust in communities is really big in the summer, right? Where it's dirt roads, wastewater management. All of these layout things are really important. So here we defined it kind of, so healthy built environments include, but not limited to, access to and availability of adequate suitable housing, clean water, nutritious foods, safe neighborhoods that promote physical activity, well-being, social interaction, mobility, and a sense of pride and cultural identity. People often, like it was a really interesting study. So this is Toronto, but the health units in Toronto and Toronto area looked at what the impact would be in a policy decision of funding public transit. So it was called the big move, getting public transit, better public transit funded in Toronto area. And they did lots of modeling, and they said that, you know, if this big public transit is funded, we will prevent at least 600 people from developing diabetes. Just if that one policy decision was made around public transit. Just because if people take public transit, they're walking that little bit more. Right? They might drive to the subway station, but they're going to walk or take the escalator up and down. There's just that little bit more walking was actually going to prevent 600 new onset diabetes. So the impact of some of those policy level decisions at community, I think, we often don't talk about, but can be huge. And certainly in a small community, what those decisions are can come out and be discussed in some of the needs assessments and that sort of thing, planning processes. So the next little bit is just looking at how specifically in approaches to community well-being, some of the things that we've been looking at doing. And then at the end of the presentation, we have a couple specific questions actually for you that we are kind of brainstorming on, and I'm wondering if there's examples in the room about where you've seen this done successfully. So within approaches to community well-being, Janet mentioned that we haven't been doing a lot on environmental health yet, but we see it really as kind of the next big important undertaking to start to look at. What we have been doing, so we've been health data or creating health status reports, health promotion, as well. We have done recently a pest control kind of pilot project looking at bed bugs and cockroaches specifically in a couple of the communities that we support. So these are the two health status reports that we've created. So one is focused on children and youth and the other on adults. It looks at reasons for nursing station visits, but as well as emergency department visits, hospital admissions, and there's regional numbers, but then there's also numbers for each community, so that in that community they understand what their rate is of admission to hospital, what they understand the main reasons that people from their community are admitted to hospital. And I think one of the things that is so important when we do that is we realize what a range there is across communities, right? When we look at even something like diabetes prevalence in age 20 and over, they're all higher, but some communities where it was 16% of adults diagnosed with diabetes. Other communities all the way up to 39% adults diagnosed with diabetes. So one approach doesn't work for every community because the outcomes are different, the settings are different, and has to be community specific. So some of the things that that we're looking at doing are more things related to advocacy and partnering with different organizations and using some of the tools that we have been able to get related to data. Building relationships with organizations that control decisions related to housing. Again, it's fascinating, this whole idea when Indigenous Services Canada was created. At the time, there was a physician that was the minister of the pre-existing INAC, and there was a physician that was the Minister for Health Canada, and both believed really strongly in the social determinants of health. And so the idea when they brought First Nations and Inuit Health Branch under Indigenous Services Canada, so moved it out of Health Canada, moved it into Indigenous Services, was so that health could work together with other sectors under Indigenous Services Canada. Now that hasn't fully trickled down to, I think it's still broad statements. We're not seeing a lot of changes necessarily in everyday policy and practice, but that was kind of the intent, or what they said was one of the reasons that they wanted that to happen, was to start having folks that work in education start working with health, housing working with health, water and sanitation working with health, because it's all related to health. And then looking at tools for households, like are there small things that can be used by households to improve health related to housing that we could be looking at doing. So I know, are most people in the room here in the housing sector? Is everybody in the housing sector? Or public works? Okay. And so one of the questions is, we can look at it a couple of ways. One of the questions is, how can we incorporate promoting healthy homes into existing health programs? So, for example, early childhood development programs, or in Ontario we have Healthy Babies, Healthy Children. So what are ways that you can incorporate some of what you do in housing into existing health programming? The other question is, so how can the housing and the health departments work together? Does that, just a show of hands right now, in the communities that you work in, do housing and health departments work together? Okay, that's great. That's great. Any examples of how they work together? Okay. Yeah. 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 Other examples from other places how housing and health works together? Yeah.
I don't know if it's necessarily purposely related, but I have to say that it's a little bit maybe not cooperatives
Hmm.
and there's a little bit of research that shows lots of functions that are for sort of the value of the housing.
Mm-hmm. Okay. Yeah. Really, you can link anything to health. That's also part of the challenge. Yeah.
If the health department ever asked the housing side to install ventilation in the house, so this would be a big thing on a regular basis, but respiratory stuff, you know, that would make a repetition to like ventilation in that house, or that would not happen.
Um,
That's example of that.
yeah, so I think it is very dependent on the healthcare provider and the nursing station, at least in our region. I know as a physician, I was often asked to write letters to the council or to the housing department saying this person needs the mold taken care of in their house or that sort of thing, but it wasn't necessarily a referral specific to, like, can you check out the ventilation? Yeah. No, yeah. But could you do that? Physicians are writing prescriptions for physical activity now, or spending time outside. Mhm. Yeah. Yeah. You have-
Hi, I'm Amy with Connect, and we have nursing conversations. We do often get referrals from community nurses that would come through us, or the CHRs, or the housing managers. So they're requesting the community, we would come and do an inspection from a health perspective. So it's not happening everywhere all the time, but there's quite a few housing inspections going on. And then often they'll bring building inspectors in, or we'll recommend the building inspector comes in, because we can't look at specific COVID issues, but we would certainly identify the things that we would probably stop or unplug or something like that. But I think, you know, it's not happening everywhere, but we do get calls from the community nurses and health doctors. I think people are really trying to connect their own housing departments and their health. We've seen a lot of, you know, a lot of collaboration over the last few years.
Marty, the public works department takes care of the water system and the septic system, and they help with the foundation, and they work together in that way. And then the health department works with the housing department with the furnace, like if you have an oil furnace or an electric furnace, it depends on the filtration system for that.
I think the other parallel with Australia, which is really important, is looking at fire safety. And we just did a study in Fort Lee, Sioux-Lookout Zone, and there are a number of houses with imminent fire safety hazards, where either the dryer wants to be vented in a way that people have a pool, or they're out of food from the wood stove, we're working to accept the houses which are
I don't have the magic answer for that. Because the challenge with health is they don't have it hasn't been built into health budgets to do that, and it's never been prioritized.
Yeah, and I think for our communities, I don't know which community you're from, but for us, for the communities that we work with, we didn't really have a clearly defined public health system. We know that EHOs such as Kevin went up north and could make recommendations, but you're making recommendations are one thing, actually doing something about it is another thing, and a lot of it comes to resources. And I think that's one of the things that we want to look at and working together with, not just the housing, but other areas of of the systems that are there in the community, is really advocating because, and how does that happen? But we certainly know that there is a huge need. And one of the things that as we're moving towards more environmental health, is working with the communities and asking them what does that look like, and as we transition environmental health under First Nations management and government, governance. Yeah. So, what to say, Mike? Yeah.
I think sometimes we get stuck on the whole maintenance piece, on the technical side, whether it's properly installing HRV, making sure that it's maintained, cleaning rain gutters and downspouts, grading. But I think there's another side to it. The home care side. Making sure that your home is clean. Simple things, dishes, mopping, and all that, right? So I think you always got to look at it two different things.
Yeah, yeah.
We're working with our family health need program, and works with families and tries to empower them.
Mm-hmm.
And so, actually, we did some research on it in Senior City, has this program called more focused on the family and children home care. So it's kind of like that song.
Mm.
I work in many homes as well, in the housing sector, in
Yeah.
housing infrastructure side.
I think certainly for First Nations communities, I mean, the way we used to live to what it is now has, it has evolved so rapidly. And then you look at the trauma that our communities and individual people have experienced. Some of it has never been dealt with, and continues to, traumatize their family and extended family. It's a huge issue, and I think when you're hopeless, you sort of, like I don't want to clean my house every day either. But you just get into that where people are not able to mobilize themselves and to look after their families or their homes, especially with I think some of the challenges that we have experienced in our communities, which is addiction, has been a huge thing that has really impacted our communities, and it really further tear down the family structure and sort of that being able to help yourself. So hopefully things will, I think we have seen some improvement, and we want to continue to support the communities get healed. Paul? So, Sorry, I can't hear you. You have to- Yeah. Natalie. We have a public health doctor. She can answer that.
There's no magic. And part of it is right now we're waiting to see. So we know that in China, where there's been, almost 50,000 individuals diagnosed with the coronavirus, and it really spread. It looks very much like a picture as if this was a new influenza virus introduced to a population that had never been exposed to it before. Right now, and there's some evidence in other countries, Singapore, where there has been more clusters, but it's still 95% of cases are just in China. So we don't know at this point in time if it's actually going to spread in Canada. The director of the WHO yesterday kind of said, it could still move in any direction. We don't know. So in the meantime, what do we do to prepare? The big focus really is on, as an individual, practicing kind of respiratory health. So it's spread the same way that coughs and colds are spread. So washing your hands lots, covering your cough up, that sort of thing is what prevents spreading influenza, prevents spreading other colds and viruses, and it would be the same thing for the coronavirus. There's different public health measures. So in terms of, like, the reason SARS died out as a virus, we haven't seen it since that outbreak of SARS, was because they contained it enough by isolating who was exposed to it and quarantining people, that there was nowhere else for the virus to go. So it essentially just kind of died out. There's been no new cases of that. So that's still a possibility with coronavirus. If you're able to, so right now what public health authorities will do is, if you've been exposed to it directly, you self-isolate for 14 days so that there's no opportunity that you can spread it further. All that being said, so how do you prepare at community level? I think it's a good reminder about pandemic planning. The last time we were really focused on that was H1N1, which is 10 years ago. So looking at kind of what are your kind of scale up plans if there were to be a number of people sick at one time, having equipment there in terms of masks, gloves, all of that, enough equipment. So it's a good time to look at those plans again and see what we need to do. When people ask me, I mean, right now the risk in Canada is there's really no risk unless you have traveled to China. So we hope that it will stay that way, but it might not. But so we don't need to make decisions about restricting travel in Canada because there's no risk in traveling to Toronto right now. That might change, 3 months from now. But in the meantime, I think your best option is going at community level, looking at your preparedness plans. Don't know if that answers your question. Yeah.
Different engineers in different specialties. Anything from network to structural, HRD, mold, quality, electrical foundation. So, out of 36 units, it cost us $97,000 knowing, sign up for test or report, they do and go take help them. For enough cases and of time and we do a study where you help on the system. So we went the other way first, so couple of weeks later, and the third week, when I looked at it, it was less than 30. We're ready to replace it. I don't know if there's 104 families in the so our initial scanning, we didn't look at the photo, it was 52 million more. But the sad thing about this is, medical officials tested individuals, children, adults, and they have to evacuate them to cities that needed capacity. So one of the findings that we found in one of the children, there was mold growing in the lungs because of overtime breathing in the air. Because after the engineers did the assessment, they know what was doing in the habit. So all 36 children have to be replaced. At the end of the day, we have 52%. And I told her, $52 million. And what I'm not wanting to do is, when the activity comes, we want everything to go. Help them to stand up and have them back. Or any other reason. So I'm not going to look at replacing all of them, all furniture, all their personal needs. But it's one of the strategies to use to address that. You know, hopefully, I mean, teaching this concept to other communities and hopefully give it to their friends, they can start doing it. And spend money. They never know what they're going to do. And then at the end of the day, I'm not sure if I say this, we slipped in that bill with 97,000, we have a money now. So that's something I wanted to mention. Never hurt there's assessments that can done. To troublesome, nothing in good troublesome, but you do need that in big assess troublesome with assessment. So very, very something to think about. But we did something. But we just, one thing we did monitor throughout this process was we looked at the conditions of our people. And they were using the facility, health facility, Mississippi, or Washington, less when they were living in captivity than what they were doing when they were living in the baby they were going to spend. The majority of the job because they were living healthy. Something to
would be huge savings for the healthcare system by fixing the housing. Yeah. The problem is often those decisions are made by politicians that have a 4-year cycle. So they're not that interested. Yeah.